Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.
You're listening to Healthcare Matters, the podcast that pulls back the curtain to help you make sense of complex healthcare economics and policy issues. With us is Dr. Robert Popovian in Washington, D.C. He's a pharmacist, an economist, and the Chief Science Policy Officer at the Global Healthy Living Foundation.
And dialing in from Indianapolis, Indiana is my very good friend and co-host Ben Blanc, our Director of Digital Production and Engagement at GHLF. Ben, how are things going today?
Well, all good here, Robert. It's been a busy time with several significant health policy developments. We've all been paying close attention to the CDC recommended changes to COVID vaccines. And on the legislative front, the House recently passed a bill that could have far-reaching implications for healthcare access across the country. So lots of information to absorb for sure.
That is absolutely true. You know, right before we got on to record this podcast, I was with a reporter who was calling me to learn more about the changes by CDC regarding recommendations of the COVID vaccine. To be honest with you, Ben, we've done a ton of research at GHLF, but also did an economic research paper with Progressive Policy Institute. I think it was beginning of last year that we released it. And in it, we clearly show that the patients who benefit most, frankly, from the COVID vaccine are elderly. We believe that it's 55 and above from our paper, but what CDC did is basically say for COVID, it's going to be a routine. Actually, it's not even CDC, right? Because it was the HHS secretary sort of announcing it. And the CDC still has to act upon it. We don't know how the sausage is going to be made after it comes out the other end. But at this point, what the HHS secretary desire for COVID vaccine is that it's going to be a routine recommendation for seniors, which makes absolute sense. They're at risk. And also the other thing that he wants is that if patient has a risk factor, that they should be eligible, or a routine recommendation for those patients. The difficulty has always been, Ben, like we've discussed in our podcast, is how do you define risk? And can it be done in the community setting where patients are not necessarily going to their primary care physician, but are in a clinic setting or a pharmacy setting where a pharmacist needs to administer the vaccine? How do they judge whether or not the patient has that risk? And that's going to be something that we need to look out for. And as we've discussed in the past, it's going to be challenging. But enough said about vaccines. Let's move on to more exciting stuff, Ben.
These changes are really a reminder that policy decisions today shape the care patients get tomorrow. And that's why we're especially glad to be joined by a leader in this space for this episode, Dr. Alison Bailey. Dr. Bailey is the Chief of Cardiology at Centennial Heart at Parkridge in Chattanooga, Tennessee.
She also serves as Physician Director at the Cardiovascular Diseases at HCA Healthcare, and she's deeply involved in advocacy efforts with the American College of Cardiology, which is the largest physician cardiology association in the country. I think it's more than physicians, actually. It's providers that work in the cardiology space, and the American Society for Preventive Cardiology.
Well, Robert, let's get started. So, Dr. Bailey, welcome to Healthcare Matters. And before we jump in, could you take a moment to introduce yourself to our listeners and share a bit about your background? I know we just shared a lot about your background, but I'm sure there's more to say. And what drives your passion for advancing cardiovascular care and policy?
Yeah, no, thank you so much. Well, first of all, thank you for inviting me to be on the podcast. I listen all the time, so I'm super excited to be here. I grew up in a rural area and saw firsthand really the effects of cardiovascular disease on underserved populations. I've always been interested in prevention, and in the world of cardiology, obviously we have a lot of work to do. Cardiovascular disease is the number one killer of all Amerians. 1 in 3 of us will die of some form of cardiovascular disease. And the key facts are it's very preventable, and we've made great strides over the last 100 years, but we've got a lot of work to do. So those are the things that really motivate me, the fact that I see these patients every single day, and it's very, very common disorders, and that there's lots and lots of things that we can do to make things better.
Well, thanks so much, Dr. Bailey, for joining us. And as you just said, cardiovascular disease remains the leading cause of death in the U.S. And after decades of progress, we're now seeing the death rate rise again. our first question to you is, what's driving that trend and what are the public health implications, especially for patients with chronic conditions like type 2 diabetes or obesity?
Yeah, no, I think that's a really important question. And there are many people out there that are working to solve this riddle. So we know, over the last 50 years, really, we've made a big impact in ischemic heart disease. So heart attacks. We have medicines like statins that help prevent cholesterol buildup, that lower heart attack risk. But during this last 20 years, what we've seen is increasing rates of overweight and obesity, which is probably driving a lot of this epidemic. So the rates of having heart failure have gone up drastically in the United States, as well as the rates of type 2 diabetes, and sort of this new concept of cardiovascular kidney metabolic disease, which kind of pulls all of those things in together with the primary abnormality being obesity. And that obesity drives all of these other diseases. And so what we know is that if you have cardiovascular disease and diabetes, you're much more likely to have a heart attack or succumb to that heart attack if you have it. You're much more likely to have heart failure. You're much more likely to end up having chronic kidney disease. And so when you start pulling all of these together, we have a population of people that are less active, less healthy, and have more health issues. So those people are sicker overall, and that's leading to this increased rates of disease and death.
And speaking of chronic conditions, cardiovascular patients rely heavily on consistent long-term therapies, many of which are small molecules. So the president recently issued an executive order supporting a longer negotiation timeline for small molecule drugs. So can you help us understand how the Inflation Reduction Act's current structure, especially the difference between small molecule and biologic timelines, how that could affect innovation and access for cardiovascular patients? Well, actually, Robert, do you want to start?
I'm sure Alison will agree that she wants probably oral medicine for her patients. It's easier to manage them, significantly less burdensome on the patient to come in and be infused in an office or a hospital or a clinic setting. The advent of innovation in the United States, technically, especially in the cardiovascular space, traditionally has been small molecules, and that's where a lot of our innovation has come, even the most recent innovations like the anticoagulant space and everything else. So what the Inflation Reduction Act did is really create a two-pronged model of sort of providing a longer sort of runway for the large molecules to have protection and then significantly lower runway for the small molecules. So in essence, as an economist, I can tell you that provides a lot of disincentives in the marketplace for pharma companies, biopharma companies to invest in small molecules because they have less time for them to be protected from IRA price setting. So that has shifted. We have seen already evidence of that being in the pipelines of the biopharmaceutical companies, that there's been a lot of shift towards development of large molecules, biologics. And beyond the issue of patients of administering these medicines or taking these medicines, and I want to hear Alison's point of view on this because she's an actual provider. I'm just a talking head, a policy talking and an economist. Beyond that, there's a cost involved in it. Even if you assume that the cost of a large molecule or a small molecule is the same, let's assume it's $1,000, there's additional cost for administering these drugs in a clinic or a physician's office that it's going to increase the cost in healthcare system. So in essence, for a legislation that was supposed to reduce healthcare costs, this is going to actually entice to have higher costly medicines coming to the market. And this is not a cardiovascular example, but I can tell you in the oncology space, my former employer, Pfizer, if you looked at their pipeline for oncology drugs, it was like 90% small molecule, 10% large molecules. And since the passage of IRA, that has shifted to about 60-40 large molecules. The ease of administration is going to be an issue. Additional cost is going to be an issue. And that's why, we need to have legislation to fix this problem, which is, in essence, it's part of the executive order that President Trump has signed. But technically, that's not enough because what they need to do is open up the legislation of the IRA and fix it. It needs to be done legislative. So, Alison, take it over. Tell us, what do you think?
I think that was perfectly stated. I think there's even one other little more specific part. In cardiology, we use a lot of these drugs that are called genetically targeted technologies. And those are things that sort of turn on or turn off proteins that your body makes to treat disease. And so it's things that aren't permanent. But these genetically targeted therapies actually fall under the small molecule, not the biologics. And the concept is that small molecules are somehow easier to make than biologics. And sort of that's why it's the shorter timeline, the 7 versus 11 years. But, the one thing that we know in cardiology is it takes a long time to get a cardiovascular drug to market. Because not only do we have to say the drug's safe, we also have to have a cardiovascular outcomes trial saying not only does it lower LDL cholesterol, for instance, but we also see a reduction in heart attack risk. And we also know that cardiologists in general take longer to adopt a new technology. So you have a longer time to get this drug to market because you have to do more intense studies. And then it takes us longer to adopt it because we want to really make sure that this drug is actually doing what we want it to do. And so in the world of cardiology, we're using a lot of these genetically targeted therapies currently for things like lowering cholesterol. So one of these medicines I can give my patient twice a year instead of having them take a cholesterol medicine or in addition to a cholesterol medicine every single day. We know that if you've had a heart attack, lowering your bad cholesterol, your LDL cholesterol, is absolutely essential to prevent future heart attacks, yet less than 50% of patients ever get to a therapeutic goal on that LDL cholesterol. And that's with all the oral medicines that we have. So one of these, new technologies, which is a small interfering RNA, which tells our body to not make this protein so that we lower LDL cholesterol. It's a twice-a-year infusion that a patient gets in an office. And so the adherence goes up, disease rates theoretically are going to go down. And so these are the kind of technologies that we have the ability to treat. Now, there are also some rare diseases that we're using these medicines for. We used to think of them as rare. There's a disease called amyloidosis, where your body develops this abnormal protein, and that can involve your heart, can involve your kidneys, can involve lots of different organs. But when I was in training, that disease had a 1-year mortality was 50, 60, 70%. Most people did not live long. And so now we have these options for these new drugs that we are just starting to see the uses for. And I'll remind you, the first small interfering RNA wasn't clinically available until 2018. So this is a brand new sort of era in medicine, but we're already limiting the likelihood that people are going to invest in these drugs. So it's incredibly important for a disease like cardiovascular disease that affects people for many, many years. And then we know that we have low adherence rates to current therapies.
Well, thanks, Dr. Bailey. And before we move on, I just want to ask one last question about the small molecule therapies. And you mentioned it earlier, they're central to how you treat cardiovascular disease today. And many of the most promising new therapies rely on them. So what are the consequences of policies that may disincentivize further development in this space?
Yeah, well, I think the biggest disincentive is lost opportunity, because if we don't put the money into the R&D to investigate these new therapies, we're never going to see the potential that we could get down the road. Business is business. If we know that you're not going to get a return on your investment, then no one's going to invest in the new drugs and the new technologies. And, as we just already heard, R&D is already changing. When you look at pro formas for these companies, they're already shifting based on the 7 versus 11-year runway and the opportunity for what's going to happen down the road with these therapies.
But can I then say something? I want to double underline what Alison said, is this precision medicine thought process. Everybody's thought process in the past was that precision medicine can only be done by large molecules, these biologics. That's absolutely untrue. And in fact, if you look at even the oncology space, a lot of the precision medicines that were coming out in the last decade have been small molecules. So this is critical because you are going to make things more expensive, harder to access, harder to take for patients. In addition, you're basically putting a barrier towards what the research was going towards, which was precision medicine through small molecules, even in the oncology space.
I'm glad you said that, because this really doesn't just go across one disease. It really does go across the entire disease spectrums. I spend my time in cardiology, obviously, but there are so many different examples. But oncology and cardiology are probably the two largest spaces right now where this exists.
Well, thank you both. And now I want to get into the science of it. I'm thinking about the promise of therapies like siRNA and ASO. I want to know what makes these approaches so groundbreaking, and how could they change the way that we treat conditions like high cholesterol or cardiac amyloidosis?
Yeah, so this is a really exciting time. So siRNA is small interfering RNA, and ASOs both target genes, but they're reversible. So they usually stop a protein from being formed. So you can turn off the protein when we don't need it, like PCSK9, which is what happens with one of the cholesterol medicines in small interfering RNA. And then if down the road, if we decide that was important, we can turn it back on. So they're temporary effects that get us to a specific clinical pathway. And so of the ones that we currently use, the cholesterol medicines are probably the most common and the most widely known in the world of cardiovascular disease. And so those are ones that stop a protein from being formed. And that protein creates a lowering of your LDL cholesterol by about 60% in most patients, which is pretty profound. And there's nothing else that does that, actually. And then for other diseases like cardiac amyloidosis, there's a protein that's being formed that's abnormal, and that protein gets deposited in your heart. So these new therapies stop that protein from being formed. Now, there's additional therapies that are being tested out there that actually dissolve the protein once it's been formed, but really, we're at the peak of what we're learning from these drugs. If you think about high blood pressure, which is an incredibly common problem in the United States, about 50% of people who have high blood pressure aren't treated. There's also some of these small interfering RNAs that are looking at treating blood pressure. So imagine instead of taking a pill or 4 pills every day to treat your blood pressure, you had a shot that you took once or twice a year that helped bring that blood pressure under control. And so these are really exciting because, one, they get kind of rid of the problem of adherence. Do I get up and do I take these pills multiple times a day, every day for the rest of my life to lower my blood pressure? Well, if you do that, that's fabulous and we really want you to, but we know that most patients don't do that. And when you increase the number of pills per day, the adherence rates go down. You're a pharmacist, we talk about this a lot. So really when we start thinking about chronic diseases that are progressive and occur over a lifetime, if we can come up with therapies that are once or twice or 3 times a year, that really changes the trajectory of what we're going to be able to accomplish for preventing disease and preventing disease progression. So it really makes everything more efficient. It improves patients' experience. When I talk to my patients who are commonly having a side effect from one of the pills and we start doing an injectable, they're in general very supportive of the approach. It's twice a year instead of 365 days a year.
Well, thank you for that. And Dr. Bailey, you mentioned earlier genetically targeted therapies. There is a bipartisan momentum behind the MINI Act, a mini act that could be big for patients. This legislation would adjust the IRA, the Inflation Reduction Act timeline for genetically targeted therapies. So can you help us understand why is this policy change important and how would it help encourage continued innovation in cardiology?
So the MINI Act would specifically target this really small group that we just talked about, these genetically targeted therapies, which probably was really never meant to be excluded from the small molecule versus biologic discussion. It's got bipartisan support because most people recognize how important these cardiovascular therapies are, not just cardiovascular, but therapies that affect genes. It was just reintroduced, it's HR 1672, and it would allow a longer timeline like the biologics for genetically targeted therapies before they come up for this Inflation Reduction Act price negotiation. And again, this becomes incredibly important because when we're talking about how are we going to get new therapies to market, not just the research trials, which are also important that we fund, but how do we get a drug from the research trial to where I'm using it in my clinic every day to reduce disease and improve patient outcomes? And that's really what we want to do. We want to be able to incentivize a research that improves the lives of the people that we take care of and keeps them out of the hospital, and ultimately lowers cost. And so this would really go a long ways to encouraging innovation and investment, encouraging looking at these new therapies, and really probably change the way that drug companies and research labs think about what they're going to invest in for the future. And again, I'll say it again, cardiovascular trials are incredibly expensive to run because we're not looking at, did you prevent cancer at 1 year, or relapse at 1 year? We're saying, did you prevent a heart attack over the next 10 years? And you have to see those outcomes. And so they're expensive trials. They include large groups of patients because we've gotten better at cardiovascular disease. So we've got 4 or 5 therapies everybody's already going to be on. And then again, it takes cardiologists and the cardiovascular care team longer to prescribe these drugs. So we know that there's more of a lag time up front before these drugs make it to market.
Thank you. And zooming out from specific policies, there's also concern about broader cuts to medical research funding. I'd like to ask, and we've talked a little bit about it, but we can expand on it. What's at stake really for cardiovascular health and innovation if we don't protect that investment? And what's your message to policymakers? And maybe, Robert, you can start here.
The message is clear, right? We've seen the numbers come out from what the HHS is going to cut from the NIH budget, especially, and it's horrendous. I mean, they're taking a sledgehammer to NIH, and I don't know if Alison will agree with me or not, but if we don't have NIH, we don't have basic sciences. And the basic science and translational science and final clinical trials go hand in hand. You don't have one, you don't have the other. That's why there's just a symbiotic relationship between NIH, academia, and pharma companies that they work together, even though it's vilified all the time in the media. It's like a bad thing, while researchers, clinicians understand the value of that to happen. Unfortunately, that's the overall. But from a cardiovascular perspective, beyond what Alison mentioned regarding the length of these clinical trials, the need to really demonstrate better outcomes before you get approval, it's also that we have effective drugs on the marketplace, so they have to be compared to what's coming out as new. So it has to be an innovation that adds to the body of the evidence, right? So it's even more difficult. The barrier to entry is much higher than, let's say, a new drug for Alzheimer's disease where there is no treatment for it. So another thing that you need to look at is beyond just innovation and policies that encourage innovation, but how do we get these medicines easier access that are already available, easier access to patients, and ensure these patients take it. So there are other things that we need to do, like lowering out-of-pocket costs, reducing the administrative burden for physicians to access these medicines. People don't realize the majority of cardiovascular disease in the United States today is treated with generic drugs. So, for example, and this is just an example of a policy issue that's being debated, right? We're talking a lot about tariffs these days, especially on raw materials coming from China and India. If you start increasing tariffs by 50% on these raw materials, it's going to have a direct monetary impact on the price of these generic medicines, because the generic drugs, the margins are so small that any kind of increase in tariffs is going to have to be passed back to the consumer. Ultimate consumer is the patient. And guess what that's going to do? Even we know a small shift in out-of-pocket costs for these patients start discontinuing these therapies, and that's where we get into trouble. So policies, it's not just about innovation, but it's also about access and ability of patients to access these medicines. How do we encourage them to take it? And unfortunately, a lot of things we're discussing today in the political space is the opposite of what we should be doing, which is improving access for patients.
I think that's incredibly well said, and I would concur with everything you said. I finished my training in 2008, and of the drugs that I prescribed this morning in clinic, probably half of those weren't clinically available in 2008, because I treat a lot of heart failure and do a lot of prevention. And so we have these brand new drugs that we have, and we have better outcomes than ever. But that is because of R&D that went into these drugs. It started in basic science labs, and then that was transcended over into bench research, into clinical research, and we saw the improvements in the outcomes of these patients. So it's incredibly important that we keep that basic science pipeline going, and that really is where the NIH fits in. And so I'm all about cutting waste and figuring out how do we make things more efficient. But we have to do that in a way that we don't lag behind every other place in the world now with our science.
So let me give you a real world example. I'm a little bit older than Alison, not too much, but a little bit older. So when I was in residency, I was doing internal medicine residency in LA County Hospital. We were supposed to do rounds with the physicians, especially the cardiology fellows. And one of the things that the attending was asking me is come up with new ideas of how to treat disease, especially in county hospitals. You know, this is majority are heart failure patients. And I came across a lot of basic research that was being done on beta blockers, using beta blockers to treat heart failure. Because you knew when I was going through training, nobody used beta blockers for heart failure. That was absolutely a no-no in this patient population. So I started looking at the research, and there was some basic research being done in beta blockers and heart failure, and some very promising effects on them. And I know now it's a standard of care within heart failure. Actually, they use beta blockers to treat it, which is, if you would have told people, cardiologists, like in 1995 or 96, that was the case, their heads would have blown up. But who's going to invest in that? Because it's not going to be the pharma companies. Beta blockers are generics. There's no money in it. So no pharma company is going to come and invest in the research and the clinical trials to be able to prove this point. So it has to come from NIH. It has to come from academia. And in clinics such as Dr. Bailey's, because at the end of the day, nobody in the private sector is going to invest on something that's already a generic drug. So that's a perfect example of, if we don't have that mechanism of funding to be able to fund this type of research, we would have lost the opportunity of examining whether or not beta blockers are effective in heart failure.
Thank you both. And maybe one last question for Robert. Do you think lawmakers really grasp what happens when policies favor biologics over small molecules? And what would you recommend to help fix that imbalance?
The short answer is no, because I don't think policymakers understand. I mean, they think of large molecules as complex molecules that you only can use for very severe diseases, significant diseases like cancers, and they don't realize that, no, that's not the case. You can use small molecules to treat very sick patients with significant disease. And we were on the verge of doing more and more of this, especially in the oncology space. And I know we were trying to do it in the cardiovascular space and other areas, even with like one of the areas that seems like nobody can stop talking is obesity, GLP-1s. But even there, we're trying to innovate the GLP-1s in the format of an oral medicine to come out into the market. Why? Because it's easier to take, it's less costly for patients to administer it. I don't think they grasp it, or whoever wrote IRA certainly did not grasp this whole thing, because the assumptions were wrong, and there were basically some old wives' tales that go on and on among policymakers that they didn't grasp the idea of how the science was evolving. The short answer is no. How do we fix the imbalances in education? We need people like Alison to go out there and talk to them and make them understand how they actually practice medicine, which is important because majority of by the way, we do have healthcare professionals now in Congress, both pharmacists and physicians that work in Congress. But I'm not convinced that they have the best understanding of what the cutting edge treatments are in the marketplace right now. And we need individuals like Dr. Bailey to go out there and talk to them and make them understand where the science and the treatments were going for patients. Alison, you want to say anything? I mean, you're there talking to policymakers all the time. You tell me if they understand these issues.
I totally agree. And I think that people still have this concept that this is something that's still 10 years down the road. These are medicines I use every single day. And so we are actually using these medicines to improve patient outcomes today. And we're not going to have that opportunity for newer therapies down the road unless this is addressed. I always like to think I'm on the cutting edge of things, but this really is pretty standard of care for us now. We've had these therapies available for a while. More and more are coming out, so I'm going to have the opportunity to use them in different patient populations. When I look back even 5 years ago and think about how we treated disease then compared to how we treat disease now, we've made substantial improvements, but I'm really worried that we're going to be coming up to a place where that changes drastically without new innovations, without funding to help us get to those new innovations.
Thank you, Dr. Bailey, for your expertise and for helping us unpack the intersection of science, innovation, and policy and cardiovascular care. And I'm no Dr. Popovian, but my big takeaway is this. If we want to turn the tide on cardiovascular death, we need smart policies that protect innovation in small molecule therapies, especially those using next-generation technologies like siRNA. This isn't just about science, it's about access, equity, and long-term public health. But I'm not the expert, so Robert, you have the last word.
As we've talked on this podcast, incentives matter. And if you don't create the right incentives in the marketplace, you will soon see that people will shift where the incentives are there. Right now, through the Inflation Reduction Act, there's incentive to develop large molecules because they have a longer runway, price protection than small molecules. So pharma companies are acting rationally. They've shifted their R&D towards more large molecules. This is bad for patients. This is bad for the economy. We're going to spend more money, not any different results. We were going towards a model that, small molecules were starting to dominate actually in disease areas were tough to treat, including cancer therapy. So incentives matter. We need to go back and change the incentives. And believe me, one of the things that is a second take I'll have on this is that cardiovascular treatment or disease is so underappreciated in the United States. We worry about cancer, and we should. Everybody's impacted. My family's impacted by cancer every day. But I can tell you, I know a hell of a lot more people who have died from cardiovascular disease than from cancer, frankly. And as we're focused on cancer fully, we have not appreciated these other diseases in cardiovascular, especially cardiovascular, which a lot of other diseases sort of feed into, like diabetes and so on, that we haven't really appreciated what the impact is into the human life. And we need to start paying more attention to that too.
Well said.
Thanks for breaking that down for us, Robert. And Dr. Bailey, thank you so much for joining us.
Thank you so much. It's been great to be on the show, and I look forward to listening to more episodes.
And that wraps up today's episode. don't forget to subscribe to our podcast on Apple Podcasts, Spotify, or wherever you might be listening so you never miss an episode. And if you have a second, help spread the word by rating our podcast, writing a positive review, and sharing with your family and friends. It'll help more people like you find us.
I want to thank Alison for coming on. I mean, it's always good to have an actual provider that takes care of patients on board, and especially talking about a very important area, which is cardiovascular disease. But to wrap this up is that if you have any questions, thoughts, or suggestions, Alison came to us. She wanted to be on the podcast. She listens to us and gave us an idea about what she wanted to talk about, and we put her on. And this has been fantastic. And so if you have any ideas, please reach out to us, let us know. And, Ben and I will decide if it's a good fit, and we'll bring you on to talk about issues. You can send us an email at podcast@ghlf.org. And we will feature you. I mean, if it's a good idea, it's a good idea. We don't have all the good ideas here in Healthcare Matters, so we're always looking for information from our listeners.
And before you go, make sure you take a listen to some of our other great podcasts on the GHLF Podcast Network. You can find all of GHLF's podcasts at ghlf.org/listen. He's Dr. Robert Popovian.
And he's Ben Blanc. We'll see you all next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.